Hello, I'm Ramona Lim, and today we'll be talking about colorectal cancer screening and how to improve your adenoma detection rate. I have no disclosures to share. And today we will discuss reviewing the current colorectal cancer screening guidelines that have been updated over the past several years, compare the available screening options and associated pros and cons, and to help identify strategies to improve our adenoma detection rate. As we know, screening for colorectal cancer is an important component of preventative healthcare, as colorectal cancer represents the third leading cause of cancer death in the US. The lifetime risk is approximately 5% in the general population. In fact, the American Cancer Society's most recent estimates for the number of colorectal cancer cases in the US in 2024 estimates more than 150,000 new cases, affecting men slightly more frequently than women, and about more than 50,000 deaths due to colorectal cancer. While the death rate has dropped significantly due to colorectal cancer over the past 40 years, from a combination of increased knowledge about the pathogenesis, advances in medical and surgical care, and the increased emphasis on widespread uptake of colorectal cancer screening programs have likely contributed to these gains, but there are still disparities in healthcare that may contribute to this increased mortality. And a disturbing trend that has been notable is that there's an increase in the younger age of onset, below age 50, where steadily since the 1990s, there's been an increase of 1 to 2% per year in this young onset colorectal cancer, and an increase in colorectal cancer deaths by 1% a year. It's estimated that more than 20,000 new cases of colorectal cancer will be less than age 50. And part of this may be that young people are often diagnosed with more advanced cancers due to delays in detection. In fact, this is a disturbing trend, such that this is now estimated to be the #1 leading cause of cancer death in men less than age 50, and the #2 leading cause of cancer death in women, same age group. Certainly, we are aware that nearly 70% of patients with colorectal cancer have sporadic disease with no prior family history of colorectal cancer, but the remaining 30% of patients do have a familial or hereditary component. And certainly the contributions of colorectal cancers in defined hereditary colorectal cancer syndromes, where a genetic mutation is identified as the cause of inherited cancer risk, really only accounts for a small proportion of those individuals with colorectal cancer, but it's certainly important, as those individuals are high risk and require intensive screening. It's also likely that there are undiscovered genes and background genetic factors that may contribute to the development of familial colorectal cancer in conjunction with environmental and other non-genetic risk factors. We know that colorectal cancer screening is intended to reduce the incidence and mortality of colorectal cancer, perhaps by removing precancerous polyps prior to the time frame of what's typically a long progression from adenoma to carcinoma over a period of 7 to 10 years. In addition, we know that colorectal cancer deaths are preventable if detected early. We know that colorectal cancer deaths are preventable if detected early. The age is still the strongest risk factor for the development of colorectal cancer and development of adenomatous polyps. Individuals at average risk should be offered screening. And we know that these interventions are important because the cancer survival is improved the earlier the stage of diagnosis. And certainly, because of this trend of younger onset colorectal cancer, The guidelines have been modified to suggest that we can offer screening for average risk individuals starting at age 45. This is a new departure, as you know, with the American Cancer Society coming out with a qualified recommendation several years ago, right before DDW. With many additional multi-society guidelines, including the U.S. Preventative Services Task Force, the ACG, and the Multi-Society Task Force that have all made qualified grade B conditional recommendations for lowering the age of screening to age 45. That being said, there's still a consensus for a strong recommendation for screening individuals age 50 and above with high quality evidence. Certainly stool-based tests are an option. They are non-invasive and require, however, annual testing for early detection and have low sensitivity for polyps. So these are great for individuals who are averse to the idea of testing with invasive measures as a first step, but may increase the uptake of individuals who are willing to undergo screening and colonoscopy if these tests are positive. Obviously, the FOBT is cheaper than the fecal immunochemical test, but does require 3 sequential spontaneously passed stool samples as opposed to a single sample, and can be susceptible to false positives with red meat intake, certain supplements. Cost of fit is higher, but it is a single examination. Either one of these exams that are positive do require a colonoscopy. But we should remember that these can be a good option for screening average risk patients. Some patients prefer these examinations and then are willing to undergo a colonoscopy once these tests are abnormal. We shouldn't be using these as in-office tests. They should be, a spontaneously passed stool at home, and we should make sure that if there is any implementation with FOPT, that we are using them without with the knowledge that there are dietary restrictions necessary. And certainly, one of the things that we as providers and even in coordination with our primary care colleagues is to educate patients and our team members that we shouldn't be occult blood testing individuals who actually report overt rectal bleeding. There's not an indication to do so. Usually it is a matter of what's clinically recommended in terms of investigations. Oftentimes it may be a colonoscopy, but certainly guidelines support using your clinical judgment if this is an outlet type rectal bleeding episode. But remember, we have a difficulty with these young onset colorectal cancers to really apply any sort of age cutoff to these presentations. And certainly rectal bleeding or any abnormal stool-based tests should be followed up with colonoscopy. Additionally, stool DNA-based testing at home is certainly an option for individuals wanting to combine FIT or the fecal hemoglobin immunoassay, along with a number of DNA mutation and methylation biomarkers to look for the risk of the presence of colorectal cancer or advanced neoplasms. This has the benefit, as we know, of at-home testing, good sensitivity for colorectal cancers, less sensitive for advanced precancerous polyps, but also a higher false positive rate. And this can be costly because the test itself, followed by a colonoscopy if positive, may lead to increased healthcare costs. However, there are also direct visualization tests that can be compared to colonoscopy and includes CT colonography. There's no sedation involved. There is still a bowel prep and can be employed for individuals who have had an incomplete colonoscopy, but there is still the disadvantage perhaps of missing small flat adenomas. Without sedation can be a good or bad, pro or con, including, the fact that there may be some rectal tube insufflation of air that can be a little bit uncomfortable as well. And certainly there's a cumulative dose of radiation and extracolonic findings that we may encounter. And certainly requires a colonoscopy to follow up any positive findings. And as we look at the most recent updated screening guidelines from the U.S. Preventive Services Task Force, they did not really have a preference for all of the stool-based or direct visualization tests. A lot of these examinations were felt to, be equally offered to individuals, including the colonoscopy every 10 years, annual FIT or flex sig, with every 10 years combined with annual FIT, as well as CT colonography every 5 years. And the difficulty of that is obviously discussing those recommendations to an individual patient to then try to increase screening uptake. So the Multi-Society Task Force has made this a little bit easier. There's been, similar recommendations in terms of frequency of exams offered, but they've prioritized the examinations where we sort of suggest that a direct visualization examination with colonoscopy be the preferred option discussed every 10 years for average risk individuals. And if that is declined, then a FIT test could be offered. Tier 2 examinations might include things like CT colonography, the FIT fecal DNA test or flex sig, and then even a tier 3 capsule colonoscopy. Of interest, neither one of these guidelines support the use of the FDA-approved septin9 assay. This detects methylated septin9 DNA. It's been approved for quite a while now, 2016. There's no patient preparation or dietary instructions, but the sensitivity is about 70% for colorectal cancer. There's no sensitivity for adenomas, and there's probably newer technologies as well that you're aware of that may be out on the market and in development in this space. So for a particular case, we have a healthy 40-year-old woman who presents for annual wellness visit. In which family history scenarios would you recommend a colonoscopy now? A, father with colorectal cancer at age 55, brother with advanced adenoma at age 45, C, grandfather with colon cancer at age 65, or D, no family history of colorectal cancer, but with bright red blood per rectum. And E and F suggest a combination of A and B only, or A, B, and D. And the correct answer includes A and B, the first degree relatives with either colorectal cancer or advanced adenomas at a young age, not the second degree relative, but certainly an individual who is deemed average risk but presents with rectal bleeding, we would offer colonoscopy. And so looking at screening based on the risk category, we could identify that average risk asymptomatic individuals may be offered colonoscopy starting at age 45 to 50 and an interval of every 10 years. Those with moderate risk, the first degree relatives less than age 60 or 2 first degree relatives at any age with colon cancer or advanced adenomas should be advised to start at age 40 and continue colonoscopy every 5 years. or 10 years younger than the earliest diagnosis of the affected relative. We also know that if there's only one family member with colorectal cancer, but at an advanced age, there is a suggestion to start at age 40, but if negative, then screening at every 10 years may be offered thereafter. And those who have just more distant relatives who are affected with colorectal cancer, to begin age screening at age 50 and every 10 years, similar to the average risk individuals. Certainly our high-risk populations with familial adenomatous polyposis and Lynch syndrome may start significantly earlier in terms of their colon cancer screening in their teens or young adulthood. And many of the guidelines suggest colonoscopy every 1 to 2 years because of how rapidly these polyps may accelerate growth to a colorectal cancer compared to the general population. There are individuals as well who are have a striking family history of colon cancer, but no identifiable genetic alteration responsible for that striking family history. They may fulfill Amsterdam criteria for what looks like Lynch syndrome, but has not had a mismatch repair deficient tumor identified, nor have had any family members with germline testing. They may that confirms a Lynch diagnosis, and therefore those individuals may be a little higher risk for development of colorectal cancer, starting at age 10 years before the youngest affected relative, and slightly more frequent intervals every 3 to 5 years. And inflammatory bowel disease, individuals who've had chronic ulcerative colitis or Crohn's colitis, and certainly those with primary sclerosing cholangitis subset may be at increased risk, and they too may undergo colonoscopy at more intensive intervals. Colonoscopy is still not perfect. We can still miss polyps. We may not reach the cecum. There may be other factors such as a suboptimal bowel prep and other quality indicators that are expected and missing from our implementation. And certainly we want to be consistent with our recommendations for screening, as well as surveillance guidelines in terms of the intervals that we advise. And we should really all be monitoring our own performance in terms of adenoma detection rate and how to improve these. The issue is that several studies have shown that patients who develop colorectal cancer after a colonoscopy, or these interval colorectal cancers, are more likely to have proximal compared to distal cancer. So there's something about the right side of the colon, logically, prep, and other factors that certainly contribute to the increased risk of right-sided colorectal cancers, despite adherence to colonoscopy. And the quality indicators that are associated with this risk of interval cancer may include the bowel prep quality, adenoma detection rates of endoscopists and their cecal intubation rates, as well as scope withdrawal time. We expect that in first-time colonoscopy for average risk individuals, that we should be identifying approximately 30% of males that are detected to have an adenoma at that baseline examination, or more than 20% in women. We also expect that at least 85% of these examinations are completed with an adequate preparation, with complete colonoscopy cecal intubation rate more than 95%, and the scope withdrawal time of at least 6 minutes to adequately examine the walls of the colon upon withdrawal. If you aren't already, it would be a good idea to start using a validated bowel prep quality rating scale during each colonoscopy, and to document this for every procedure. This takes out the subjectivity of what's considered a good prep, an excellent prep, a fair or poor prep. One example is the Boston Bell Prep Scale, which assigns a score to each of the three segments of the colon, right colon, transverse colon, left colon. Each segment can get a score of 0 to 3 in terms of how poorly to how well that segment is visualized. So for an individual who's not had a resection, has a complete colon, and has an excellent prep, we would expect that they have a perfect score of 9 out of 9 for a perfectly clean colon. And what we know is that Boston Bowel Prep scales, where the score of 6 or more is considered adequate for a 10-year follow-up. Certainly poor preps of 2 or less for the entire colonoscopy for Boston Bowel Prep would be ones where unequivocally repeating a colonoscopy within a year would be identified. I think there's less consensus for what the intervals should be for those who achieve scores of 3 to 5. But this is important because poor bowel preps are associated with more than a third of adenomas that are missed at 1 year. And the miss rates for advanced adenomas are similar. We can miss more than a third with an inadequate prep. We want to make sure that we can identify lesions that are greater than 5 millimeters and identify individuals who should have a repeat examination within a year. That can include an examination the next day with ongoing prep, or to start over and really identify where were the shortcomings with the bowel prep. Was it the fact that a split dose preparation was not employed? There are good data supporting the fact that completion of at least the second half of the prep completed within 3 to 8 hours of colonoscopy time does improve prep quality. This can be logistically challenging for those who need to travel or who feel that they have a slower response to some of the purgative preparations, but is certainly important. So we also would want to emphasize, the support necessary for making sure that the nausea or vomiting, the prep itself, and tailoring the prep to an individual may help improve that quality, so that when the colonoscopy is repeated, that the quality of the prep does not negatively impact your results. So in order to improve, we want to make sure that our individuals, our patients, receiving the bowel preps in a timely manner. Are the instructions easy to understand? And is there guidance from nursing or other staff for individuals who have questions? And we also need to pay attention to the evolving guidelines surrounding GLP-1 agonists that might decrease gastric emptying time, may cause constipation in some individuals. And that may need to adjust not only what we do in terms of our bowel preps, but also the guidelines where the anesthesiology guidelines may differ a little bit from ASGE guidelines regarding how long before exams that GLP-1 agonists should be held prior to endoscopic procedures. We also emphasize that careful withdrawal time, at least 6 minutes of really carefully examining the colonic walls, particularly the right colon. The right colon we know can be susceptible to prep issues. The right colon is also where there may be a predominance of those broad sessile-serrated polyps that can be very subtle despite their large size. And we also know that the right colon happens to also be an area where high-risk individuals such as those with Lynch syndrome, have a predilection for right-sided neoplasm. So we want to examine the right colon twice, either in retroflexion, which can be straightforward to do with practice, versus even looking at the right colon twice in forward viewing if you don't have the comfort or the positioning necessary to achieve the retroflexion in the cecum. I think the retroflexion in the cecum is somewhat easier with a more flexible, for example, pediatric colonoscope as opposed to an adult colonoscope. It can also, be scope factors, such as how straight is the scope once you're in the cecum. If there's a complete loop that is still present and you don't have good one-to-one, it may be a little bit more challenging to achieve retroflexion, but certainly worth doing, practicing, and really achieving success as much as possible. We want to carefully insufflate and examine behind folds. And there's been numerous, studies that have looked at water-aided exams, whether it's water immersion or water exchange, that might enhance adenoma detection rate. And certainly that team-based approach is very important, not only the endoscopist, but the primary assistant with the examination, whether it's a trainee, the endoscopy nurse, the tech, all eyes on the screen, and really being able to detect abnormalities together may help improve our adenoma detection rates. And other technologies are certainly commonplace to have high definition colonoscopes and high definition monitors that are widescreen that enhance our ability to visualize that color contrast necessary to identify polyps. Chromoendoscopy can be a little bit laborious, but certainly the digital technologies that involve endoscopic image enhancement, like narrowband imaging, blue light imaging, eye scan, magnification endoscopy. These are all tools that are often part of the equipment that we are already using that can be helpful to identify polyps. They can also be very helpful at helping to assist cleaning the colon when the colon has got that very diffuse coated bilious mucoid sticky secretions all over the right side. So those technologies can actually be very helpful at helping to identify what should be flushed in order to allow good visualization. And certainly artificial intelligence is another way where these technologies, as they continue to improve, are more accessible, are perhaps less expensive, maybe technologies that might help us to identify polyps. Other techniques and technologies that may help improve our detection are those that employ for example, distal examination, distal attachment caps to endoscopes that may help us to examine behind folds, or panoramic devices, full spectrum endoscopy, FUSE, and the GI system are all other technologies that are available as well to help improve adenoma detection rate. All of these new technologies may help increase the likelihood of detecting small polyps, but for now, the role of technologies hasn't been studied extensively in surveillance cohorts, and so there hasn't been a current impact on surveillance intervals. And our recommendations as well then have also been updated for, the follow-up colonoscopy after polypectomy. After that high quality colonoscopy, we risk stratify our follow-up. So it doesn't mean that they've ever had a polyp, they automatically, everyone comes back at 5 years. There is good evidence that we can sort of extend out the interval for the follow-ups, such that if there's a normal colonoscopy, only hyperplastic polyps, that are sub-centimeter, that a 10-year follow-up is appropriate. The 1 or 2 adenomas that are sub-centimeter that can actually be followed up in 7 to 10 years. Sessile serrated polyps may have a more concerning emphasis for follow-ups of 5 to 10 years for similar size 1 to 2 sessile serrated polyps. And then these intermediate intervals where we do 3 to 5 years for 3 or 4 adenomas, or sessile serrated polyps, or a large hyperplastic polyp, which is unexpected, greater than a centimeter. 3 years for those with more concerning features, whether it be advanced histology or more numerous polyps, and certainly 10 adenomas in one exam would justify a 1-year follow-up, in addition to potentially even a genetics evaluation to identify if there's a hereditary susceptibility. And after those first colonoscopy surveillance, the subsequent examinations might also be extended accordingly if there are reassuring findings, or more frequently if that first surveillance examination, the second exam, is more concerning in terms of adenoma histology or numbers. Performing colonoscopy is not without risk. As we know, the risks of undergoing colonoscopy increase with age. Many of the concerns are related to cardiopulmonary complications as a result of the sedation necessary during examinations, but even risk of perforation increases, the risk of bleeding increases, and certainly these individuals may have a significant host of comorbid conditions that may make colonoscopy more difficult to complete. The U.S. Preventive Services Task Force still advises that these be offered to age 75, and then to individualize from 76 to 85. And that beyond that, most individuals will not benefit. The risk may exceed the benefit to that particular individual, and would not support ongoing colonoscopy screening. So in conclusion, we have many available acceptable colorectal cancer screening strategies which exist that can help optimize improved adherence of colorectal cancer screening in the population. We understand that there are some limitations to implementation, and recognize that some of the healthcare disparities do need to be addressed to improve adherence across the board. We know that colonoscopy may allow detection and removal of precancerous lesions, which may prevent colorectal cancer, but we do still have limitations in preventing right-sided colon cancer. The evidence is clear. We can improve our adenoma detection rates by trying to optimize bowel preps, engaging our patients in the process to tailor and improve bowel prep quality to produce a high quality colonoscopy exam. And then for us to be mindful of the withdrawal time, that we are examining colons, really looking carefully at the right side of the colon and behind folds where we may miss significant lesions, and to continue to test and utilize newer technologies that might help us improve our adenoma detection rate. In summary, though, the best screening test is the one that gets done. Thank you for your time, and I look forward to your questions in the Q&A session.